صباح النور دكتور. أنا
صوت واضح؟
واضح دكتور.
We continue the sessions of lectures regarding malignant hematology. We just finished chronic myeloid leukemia and chronic lymphocytic leukemia. As we define chronic myeloid leukemia, CLL is a Philadelphia positive MPN. What is MPN? What is myeloproliferative neoplasm? As you know, we have HP, white BC, platelet. The malignant disease of HP, of RBC, we call it polycythemia rubra vera. The malignant disease involving platelet, it's called ET, essential thrombocythemia. And when there is a malignant fibrosis inside the marrow, we call it myelofibrosis. CML, as we mentioned, it is a Philadelphia positive. All these four malignant disease called MPNs, myeloproliferative neoplasm. We define it as a clonal proliferation of marrow precursor cells depending upon these precursor. It is RBC, polycythemia vera, it is platelet, ET, it is fibrosis, myelofibrosis, it is white BC, there is a CML. So MPN is a clonal proliferation of marrow precursor. We say it is a clonal disorder. So you should have clonality markers. The clonality markers is JAK2, MPL, calreticulin, and Philadelphia. The first clonality marker, Philadelphia. If it is positive, it is CML. If JAK2 positive, it is polycythemia vera. If calreticulin and MPL positive, it is ET. So the clonality marker is JAK2, MPL, calreticulin. We started by polycythemia rubra vera, mainly attacking age of above 30, above 40. The diagnosis is incidental with high HP. Symptoms usually of hyperviscosity, lassitude, loss of concentration, headache, dizziness, blackout, pruritus, and even epistaxis. Some patient presented with a manifestation of peripheral artery disease or central artery disease like CNS, cerebral vascular accident, or may attack not arteries, may attacking veins resulting in venous thrombosis. Peptic ulcer is a common and usually complicated by bleeding. Patients are often plethoric, and many have a palpable spleen at diagnosis. We have a special symptoms occur in polycythemia vera. We call it erythromelalgia. Erythros, redness, melas, extremity, algia, pain. It means there is a burning sensation at hands and feet. The cardinal manifestation of erythromelalgia, pain and burning, pain and warmth. So erythromelalgia, what is erythromelalgia? Erythromelalgia, it is a feature of polycythemia rubra vera, characterized by pain and burning. It is a neurovascular pain. Erythromelalgia, it is a neurovascular pain. The patient feel pain and burning, called erythromelalgia, feature of polycythemia vera. How do you investigate those patients with suspected polycythemia? As we mentioned, polycythemia is a malignant disease of RBC, so you should have a high hematocrit. And we say that polycythemia is one of the clonal disorder, so you should have one of the clonality marker, which is a JAK2. High hematocrit plus JAK2 positive mutation. You may have high neutrophil, high platelet. How do you manage those patients with polycythemia? Because of risk of thrombosis, as we mentioned, peripheral arterial, central CNS, you need to give antiplatelet, aspirin. And because the basic pathology is high hemoglobin, you need to decrease RBC burden by remove it from circulation. And this is done by venesection with the target hematocrit below 45%. Can we use a drug to lower RBC? Yes, we can use hydroxycarbamide, hydroxyurea, or even alpha interferon. And this is maybe used not only to decrease RBC, but to relieve the burden of splenomegaly. What about the risk of polycythemia vera? We have two major risks of polycythemia vera. At a long term, after 15 years, those patients may be transformed to MF, myelofibrosis, or acute leukemia. This is the risk of polycythemia, risk of transformation to more aggressive disease. What about ET, essential thrombocythemia? This is a clonal disease. So we have a clonality markers. Clonal proliferation of megakaryocytes results in raised circulating platelet. Although the platelet is high, but it's often dysfunctional platelet. Almost always, any case with high platelet, you should at first exclude reactive causes, because the reactive causes is the commonest cause of high platelet and may have a positive clonality marker JAK2, and usually, as usual, those with MPN in general may be diagnosed incidentally, asymptomatic. Patient usually at age of 60 with risk of vascular occlusion or bleeding. This picture shows the blood film of very, very, very high amount of this small fragment, which is called platelet. This is a thrombocytosis, high platelet count. This is a giant platelet reaching to the RBC size. Otherwise, all blood picture is filled with many platelets. Usually we classify ET, essential thrombocythemia, according to the age and platelet count and vascular event into low versus high risk. Low risk, younger age group with the platelets less than 1 million without vascular effect. And the treatment is in these cases is usually aspirin. While those with above age of 60 with platelet more than 1 million with risk of vascular event, definitely we need to decrease the platelet count to avoid any thrombosis by hydroxyurea, a drug that can use as a cytoreductive agent, and we may use anagrelide. What about myelofibrosis? Again, it's a clonal proliferation of megakaryocyte, not secreting a lot of platelet, but secreting a fibroblast activation. Those with myelofibrosis usually, in general, MPN, myeloproliferative disorder, including CML, usually attacking elderly above age of 50, may present with weight loss, night sweating, huge, one of the differential diagnoses of huge splenomegaly in medicine, myelofibrosis. Blood film may show a leukoerythroblastic picture with the classical teardrop. Definitely clonality marker in this case is JAK2 positive. Because the marrow filled with fibrous tissue. So when you do a bone marrow aspiration, there is a dry tab, diluted blood, nothing aspirated. The diagnosis is confirmed by biopsy when the marrow is filled with fibrosis. This is a case of myelofibrosis. Look to this patient. He's wasted, underweight, cachectic, but with huge splenomegaly. Very, very huge, reaching even to umbilicus, and even may cross the umbilicus. Post-mortem, this is the spleen. This is not only a huge spleen, this is even a bulb, a visible spleen. Look to this bulb. It is not only a palpable, it is even visible spleen. This is a very large splenomegaly post-mortem. This is a classical teardrop. This is a classical teardrop cells اللي هي شكلها مثل الدمعة. Classical feature of myelofibrosis. How do you manage those patients with myelofibrosis? We give blood for anemia, we need folic acid, hydroxyurea again for any splenomegaly or cytosis. We have a specific target drug for JAK2, we call it ruxolitinib. Jakavi can be used as JAK2 inhibitor again to relieve any evidence of splenomegaly. Transplant, hematopoietic stem cell transplant. Usually we offer it in young patients below age of 40. So MPNs, including the 4 elements of blood: white HB, malignancy polycythemia, platelet malignancy ET, fibrosis, myelofibrosis, and CML. All of these are clonal proliferation of a precursor and usually attacking elderly. We have a clonality markers. Okay. Look to this case. We have an elderly woman, old age woman. This is a new subject, a new lecture, a new session. Complaining from backache. Backache is a very common symptom. When does the backache become sinister? Sinister means bad, means dangerous, means something serious. Backache is usual symptom. But when does the backache give us a clue of bad backache, a sinister backache? When the backache associated with pallor, when the backache associated with renal impairment, when the kidney is failed, renal impairment. Example, CKD, and the feature of CKD, renal failure, backache plus renal failure is a sinister backache. Backache with feature suggestive of hypercalcemia. Hypercalcemia may cause stones, bones, pain, groans, abdominal pain, pancreatitis, and even moans, psychiatric moans or acute confusion. These are features of hypercalcemia, clinical feature of hypercalcemia. Stone, renal colic, bones, bone pain, groans, abdominal pain, psychiatric moan, confusion. When the backache associated with hypercalcemia, this backache is a bad backache, is a sinister backache. Any patient with backache and these features, pallor, renal impairment, feature of hypercalcemia, you should send for skull X-ray. When you send for skull X-ray and you find such a typical multiple osteolytic lesion, these are multiple lytic lesion, as if the bone, the skull bone is eaten by these lesions. We have elderly patient with backache, complaining from pallor, renal impairment, hypercalcemia, and the skull X-ray shows a multiple lytic lesions, as if the bone is eaten. The diagnosis will be multiple myeloma. What is multiple myeloma? These are the features of multiple myeloma. We called it CRAB. CRAB, C, hypercalcemia, R, renal failure, A, anemia, B, bone lytic lesion. These are CRAB, and we call it all the CRAB when occur in elderly. mnemonic old crab. When it's occur this feature when occur an elderly backache, an elderly plus hypercalcemia, renal impairment, pallor anemia, and sclerolytic lesion. This is a case of multiple myeloma. These are the size of multiple myeloma in the skull, a multiple lytic lesion in the skull. We call it a pepper pot, اللي هي multiple lytic lesion in the skull. Look to this lesions. These are bone eaten by these myelomas. Look to this skull. Is eaten. This is a real skull, a real bone that be eaten by malignant cells. Look to this skull. Even there's an opening in this. How do you investigate? What do you think? What's going on? We need, because the lesion is inside the bone, we need to do a bone marrow aspiration and biopsy. What is the result? When we aspirate the bone marrow, we found a big, large cells with large eccentric nucleus surrounded by a halo. Look to this halo. Almost always, the cells is very large, blue in color, with big nucleus, and the nucleus is usually eccentric and had a halo. This is a classical plasma cell. This is a classical of plasma cell. We need to know this plasma cell is reactive to infection or it is clonal. What is clonality? We almost always say clonality is a feature of malignancy. Clonality, it means all cells carrying the same ID, the same aggressiveness, the same killer character. All of them are the same identity, the same killer aspect, the same feature. This is a clonality. So clonality, when all cells are monomorphic, when all cells carrying the same feature. Normally, the cells polymorphic carries a multiple function when it is carrying the same function, a killing function, a bad function, a bad idea. It is called the clonality. We usually send for flow cytometry as we mentioned it in CLL, and we found such a plasma cell, a big large cells with blue cytoplasm and big nucleus, eccentric, and a halo. This is a plasma cell. So B cell, usually, normally white B cell, we classify to B cell and T cell. The B cell is differentiated into plasma cell when it needs to be secrete antibodies. So the plasma cell secreting antibodies. The antibodies flag cells for destruction. The antibodies usually used to opsonize cells to activate the macrophage to be engulfed. When there is a bacteria, the plasma cell normally secreting antibodies. The antibodies usually attaching for such bacteria. These antibodies is usually identified by a macrophage, and this will be eaten. So the plasma cell secreting 1,000 and 1,000 from immune globulin, from antibodies. A lot of antibodies and immunoglobulin are secreted from plasma cells. Look to these antibodies. How can we measure these antibodies? How can we measure these immunoglobulins? Usually, we do what we call it a serum protein electrophoresis. These antibodies or myoglobulins are proteins. So when we do SPE, serum protein electrophoresis, we can identify two types of protein. Usually we have albumin and we have globulin. Globulin, we have alpha 1, alpha 2, beta, and gamma globulin. This is normal. Normally, the serum protein electrophoresis, looking for the antibodies, we have one spike, we call it albumin. The second spikes are by globulin, alpha 1, alpha 2, beta, and gamma. In case of multiple myeloma, because the plasma cell secreting the same immunoglobulin, because it is a clonal plasma cell, so it is usually secreting only one immunoglobulin, one antibodies, not a multiple antibodies like this is in normal. This is a polyclonal, a normal person. But when the case is myeloma, usually the secreting malignant clonal plasma cell, a single monoclonal protein. We call it a monoclonal protein, a gamma spike. A gamma spike. There is a second spike and maybe even bigger than the first spike. This is a monoclonal protein. We call it M spike. So the diagnosis of multiple myeloma is depend upon the plasma cell and marrow and upon the clonal protein diagnosed by M spike by serum protein electrophoresis. This is the M spike, M monoclonal protein at the area of gamma region. This is the M spike. This is normal protein. Normally we have no spikes. We have a multiple small spikes with single spikes of albumin. The green color is denoting the normal distribution of the protein, while the red color, this indicates a bad protein, a bad spike, a clonal spike secreting by monoclonal antibodies secreting by malignant clonal plasma cell. This is a serum protein electrophoresis of multiple myeloma. Yes, this is a multiple myeloma. Usually multiple myeloma, clonal plasma cell neoplasm secreting monoclonal protein detecting by M spike in serum protein electrophoresis by plasma cell at the bone marrow. Presented usually in elderly with backache. The backache is a common symptom. To be a sinister, a bad backache, it should be associated with pallor, should be associated with renal impairment, should be associated with hypercalcemia and features. How do you treat? Definitely you have a specific agent to treat multiple myeloma. We call it bortezomib. يعني لا تتعبوا نفسكم بهاي الأسماء الصعبة، ما مطلوبة منكم بس للاطلاع يعني خاف تسمعون بها. We use a lenalidomide, Revlimid, and we use a monoclonal antibody daratumumab, Darzalex. And because of hyperproliferation of plasma cell inside the marrow and risk of fracture, bone fracture, we use bisphosphonate zoledronic acid. We call it Zometa. And definitely your job at emergency room, when you are facing a patient with multiple myeloma, don't give these drugs, but you give a steroid, dexamethasone. Steroid will result in reduction of plasma cell. But what you use at emergency department, you give a hydration to dilute the hypercalcemia, you give a painkiller, and you use a steroid, dexamethasone. So we just finished a multiple myeloma. Look to this another case. A young patient presented to you with high-grade fever. young with high-grade fever. By the history, he has a nocturnal sweating, and the sweating is drenching sweating, aggressive sweating, severe sweating. He recorded to has a significant weight loss, young with fever, night sweating, drenching in nature, with significant night sweating and significant weight loss. On examination, we detect a palpable large cervical lymphadenopathy. But this lymphadenopathy is associated with significant weight loss, with significant fever, with significant drenching sweating. These features are sinister features, like the feature of backache in multiple myeloma. All of them, now and then, may subjected to pain in the neck due to lymphadenopathy because of simple tonsillitis, simple sore throat. But what are the sinister features of such lymph node? When the lymph node is associated with drenching sweating, weight loss, prolonged fever, this lymph node is a sinister lymph node, is a bad lymph node, carries something serious. So, what do you think? What's going on? What do you need to investigate? Because this lymph node carries a sinister feature, drenching sweating, with marked weight loss and prolonged fever. We need to get it out. We need excisional biopsy. We need to remove it. When we remove such lymph node by excisional biopsy and subject it to histopathology, we detect a binucleated large cell inside lymph node. We should know this is clonal or not to say it is malignant or not. We should assess clonality of this by big cell. So we send for what we call it immune histochemistry. We stain this lymph node to detect any evidence of clonality. The staining reveals what we call it a Hodgkin lymphoma. These lymph nodes carrying a Hodgkin lymphoma. These are binucleated big cells inside the lymph node called Reed-Sternberg cell, or owl's eye appearance. Typically has a bilobed nucleus that gives us an owl's eyes appearance, owl eye appearance. It's called Reed-Sternberg. So what is Hodgkin lymphoma? It is a clonal B-cell malignancy that develop a lymphatic system. This is a normal cells. When it is look to this abnormal cell, it say, there is something wrong with you. She say, who? It is owl eye appearance. So when it is attacking a lymph node, the diagnosis need excisional biopsy. And usually spreading, this malignant cells spreading in orderly fashion to adjacent lymph node. It is go from lymph node to adjacent lymph node in orderly fashion. So it is spreading to next. This will spreading to this, and this will spreading to this. Usually, the lymph node is paleless lymphadenopathy, but carries a feature of malignancy we call it a B symptoms, fever, night sweat, weight loss, and may be associated with pruritus or even hepatosplenomegaly. So Hodgkin lymphoma divided into 4 subgroups: nodular sclerosis, mixed cellularity, lymphocyte rich, and lymphocyte depleted. This is a histopathological classification. Staging, we depend upon the number of lymph nodes. Single lymph node is stage 1. Lymph node above diaphragms is stage 2. Lymph node above and below diaphragm, stage 3. And disseminated everywhere, it is a stage 4. Carrying no symptoms, it is A. When it is carrying a B symptoms, there's a fever and night sweat, this is a B. So stage 1, single lymph node, stage 2 above diaphragm, stage 3 above and below diaphragm, and stage 4 everywhere. Treatment of Hodgkin lymphoma. Usually we treat Hodgkin lymphoma by chemotherapy. We call it ABVD. A for adriamycin, B for bleomycin, V for vinblastine, D for dacarbazine. مو مهم تحفظونها ولا حتى مهم تعرفون ال ABVD, but it is usually a protocol used to treat Hodgkin lymphoma. You should know that Hodgkin lymphoma is 90% in early stage achieve complete remission, and we can reach even cure, in contrary to 70% of those with advanced stage can be cured. Hodgkin lymphoma is one of the malignancies that can be cured by chemotherapy. There is a very good prognosis, and this depends definitely upon the stage. Early stages usually carry 90% chance of a cure. We're already talking about a young age group. What about the elderly patient? An elderly man presented with lymph node. And the lymph node of this is not respecting anatomy. It is not separating from lymph node to its adjacent lymph node. It's separating from neck to bowel. This is a big mass inside the colon. Cervical lymph node plus a lymphadenopathy somewhere else, even reaching to the brain. So such pattern of lymph node not respecting anatomy, not separating from lymph node to adjacent lymph node, as in patient with Hodgkin lymphoma. So this lymphoma is different from Hodgkin lymphoma, usually attacking elderly, usually didn't respect anatomy, can attack every organ, everywhere, from CNS to bone, from CNS to bowel, from lymph node to heart, from lymph node to neck, everywhere. Didn't respect anatomy. It's not spreading arterily. Even the skin. This malignancy even can attack the skin. It is lymphoma, but didn't respect lymph node. Let's go outside lymph node, any system. When we took this lymph node in the neck and we staining it to say it is clonal or not, we detect not Hodgkin lymphoma, a non-Hodgkin lymphoma. So lymphoma, we have 2 types of them. We have Hodgkin lymphoma that occur in young age group, that respect anatomy, spreading only in the lymphatic system. So the spreading, we call it nodal spreading. Usually respect nodal area. If it is in the cervical region, can be reaching to the axillary region. Only lymph node. To an inguinal region, to the spleen. Only respect the lymphatic system. In young, nodal, separating from lymph node to other. While when the case is in elderly and the lymph node and the disease separating from the cervical lymph node to CNS, non-lymphatic tissue, from cervical to bone, from cervical to skin, from cervical to bowel. This is Hodgkin or non-Hodgkin? Definitely, this is a non-Hodgkin lymphoma. So when you want to put a differences between Hodgkin lymphoma and non-Hodgkin lymphoma, Hodgkin lymphoma is often localized to a single axial group, cervical, mediastinal, periaortic, while non-Hodgkin lymphoma may involve peripheral node. The separating is orderly by contiguity, while in the non-Hodgkin lymphoma, the separating is non-contiguous. Mesenteric lymph node will dire ring rarely involved, while in the non-Hodgkin lymphoma, it is commonly involved. Usually, Hodgkin lymphoma does not attacking extranodal organ, which is a feature in non-Hodgkin lymphoma. The extranodal involvement, it is a feature of how do you treat? What is the treatment of non-Hodgkin lymphoma? Yes, it is a chemotherapy. As we said, in Hodgkin lymphoma, we use a chemotherapy called ABVD. We use a chemotherapy called R-CHOP. مو مهمة من تعرفونها وتحفظونها بس معلومة يعني nice to be learned that Hodgkin lymphoma protocol is ABVD, the non-Hodgkin lymphoma protocol R-CHOP. No one will ask about this. ما حد راح يسألكم عن ال ABVD or ال R-CHOP. It's just an information. What about the prognosis? As we say that the prognosis of non-Hodgkin lymphoma is bad, is not like the prognosis of Hodgkin lymphoma. The prognosis of non-Hodgkin lymphoma may decreasing, reaching to the low level, reaching 70%, 60%, 50%. And even we have a subtype of non-Hodgkin lymphoma, we call it a low grade, which is totally incurable. We can only cure an aggressive lymphoma. We call it diffuse large B-cell lymphoma. The cure rate reaching to 60% only. So the prognosis definitely in Hodgkin lymphoma early stage reaching 90% is better. So when we summarize our lecture, that we have a lymph node in yang with a bad sign of fever, weight loss, think of Hodgkin, and this is separating from the node to another node. Go for excisional biopsy, you may find a redisturbing cell with a staining clonality, and this is a Hodgkin treated by chemotherapy, cure reaching 90. When you're facing an elderly with cervical lymph node reaching to the skin, to the CNS, to the bowel, the separate extranodal, go for biopsy and the result will be Hodgkin? No, it is non-Hodgkin, and the prognosis is usually not as good as Hodgkin lymphoma. Hodgkin and non-Hodgkin lymphoma, both of them are treated by chemotherapy. By this, I think we reach to the end lectures in hematology. We cover the most important benign and hematological aspect diseases of hematology. Any question please؟ صف خامس على المحاضرة. Any question please? أي سؤال؟ احنا أخذنا ال MPN، هوجكن ليمفوما، نون هوجكن ليمفوما، وأخذنا المالتيبل مايلوما. فإذا أكو أي سؤال أي استفسار. أي شيء ما واضح؟
شكرا جزيلا دكتور.
استفسار والأمور واضحة إن شاء الله. إن شاء الله simple واضحة important simple and easy. يلا إن شاء الله بالتوفيق، مع السلامة.